Great, new guests are added to the meeting. Let's see more details. Great. For those who wants to record this, the recorded version will be uploaded on the OMNI-RÉUNIS website. Okay, thank you everybody for joining the OMNI-RÉUNIS session.
No, let's wait a few minutes.
Sure, Professor. Sure.
Usually, if the Zoom meeting is scheduled for 11, we give 3, 4, 5 minutes. People usually join like a few minutes late. So it's normal to wait 2, 3 minutes.
For sure it is. Thank you.
So, Sana, do you want to stop recording and start it when you are about to start so that we just take this time more?
Okay, great. Thank you everybody for joining our 16 sessions of OMNI-RÉUNIS seminar. Of course, it is the first one in the new year 2024. And wish you all have a start great works in the great new year. And let me share the screen of right OMNI-RÉUNIS. This is our 16th seminar. And we starts this one as the beginning of 2024. As always, we have land acknowledgement. We acknowledge the land the OMNI-RÉUNIS Network head office located on York University recognize that many indigenous nations have long-standing relationship with territories upon which York University campus are located that precede the establishment of York University. York University acknowledges its presence on the traditional territory of many indigenous nations. The area known as Tikaranto has been caretaken by Anishbek Nation, Haudenosaunee Confederacy, and Huron-Wendat. It is now home to many First Nations, Inuit, and Métis communities. We acknowledge the current treaty holder, the Mississauga of Prairie First Nation. This territory is subject of the Dish with One Spoon Wampum Field Convent, an agreement to peacefully share and care for the Great Lakes regions. About the Super Spreader Seminars, the OMNI-RÉUNIS Super Spreader Seminars welcomes faculty members, OMNI-RÉUNIS affiliate, and highly qualified personnel, HQPs, including postdoctoral researchers and graduate students, to showcase their research, promote their ideas, share their research experience, and establish connection among the various branches of the network. It is a platform to spread scientific knowledge about the One Health research framework and research progress of 30 plus OMNI-RÉUNIS HQPs within the network's scientific research community. These seminars facilitate knowledge exchange within OMNI-RÉUNIS, the emerging infectious disease modeling, EIVM networks, and the collaborating scientific community. Today, our main speaker is Dr. Woldegebriel Assefa Woldegerima. Thank you, Dr. Woldegerima, for accepting our invitation. He is a faculty member of Assistant Professor of York University in Math Department. Before his recruitment to York University, he was a postdoctoral research fellow at Mathematical Model and Method in Bioscience and Bioengineering Lab at the University of Pretoria, South Africa. He has also worked as a predoctoral research associate at Lehigh University in USA, as an assistant lecturer at the University of Pretoria in South Africa. He has worked as a lecturer at Melek University in Ethiopia and as a teaching assistant at Ames, Cameroon. It's great to have you, Dr. Woldegerima.
Thank you very much. Thank you everyone for joining us today, and thank you for the invitation.
Thank
And
you.
yeah, okay.
Yeah, we are going to hear
Yeah.
the title of the talk will be about quantifying the basic reproduction number and underestimated fraction of Mpox cases around the world at the onset of outbreak, a mathematical modeling and machine learning based study. The current global outbreak of Mpox, which started in April 2022, has different epidemiological and clinical features compared to the previous Mpox outbreaks. Sexual contact has hypothesized as the major transmission route for the disease in this outbreak. They divided the population to high-risk group and low-risk group, considered routes of transmission, sexual and non-sexual, estimated basic reproduction number for some different countries, and let us hear from him. Let me stop sharing. You're very interested to, yeah. Could you please share your slide, Dr. Woldegerima?
All right. Okay. So start sharing.
Yes.
Okay. I hope you can see my screen. All right.
Yeah,
Can you
it
see
is great. Yeah.
Okay.
Great.
Hello, everyone. Thank you again for joining us today virtually, and good to see you. Hopefully, we will meet in person sometime in the near future. Today, I'm going as a part of the Super Spreader Seminar series at the One Health Modeling Network for Emerging Infections. I'm going to talk on a study that we have been working on with our collaborators, where we are going to talk about the dynamics of monkeypox, but mainly today I'm going to talk about the mathematical modeling by considering adaptive behavioral change, which is the first part of the talk will be mainly on the mathematical modeling part of the dynamics. And the second part of the talk will be on the use of machine learning techniques to estimate the basic reproduction number for about 16 countries. And then again, we will also extend this result to estimate the underreporting or underestimation cases of monkeypox for different countries. Particularly, we'll consider about 16 countries. So the first part of the talk will be, I just want to make clear here that the first part will be more or less about mathematical modeling of the transmission dynamics of monkeypox by considering adaptive behavioral change and risk compensation. And the second part will be on the machine learning, the use of machine learning to estimate and quantify the basic reproduction number and estimate underreported cases. So this is a work with some mentors and collaborators here. Some of them, I'm going to go to the next slide. All right. So I have a collaborator, Professor Nicola Bragheski, who is now a professor at the University of Parma in Italy. Previously he was a postdoctoral researcher at York University, and we have Sarafa, who is also a researcher at Los Alamos laboratory in the United States. We have Dr. Chin Han, who is a postdoctoral researcher at York University. We have Professor Jude Kong, who is also a professor at York University. And we also want to acknowledge the funding support that we received from the Canadian Institute of Health Research and the Natural Sciences Engineering Research Council of Canada. All right. So before I directly proceed with the mathematical model and the machine learning algorithm, I would like to start with a brief introduction about the epidemiology and biology of monkeypox. And as we already have heard probably from the news or you read from different research outputs, monkeypox, probably abbreviated as Mpox, is a viral zoonotic disease which is caused by orthopox virals, which are an infectious agents which are considered as a zoonotic traits. And it has been known that the monkeypox was endemic in many Central and Western African countries. But recently, in 2022, there was an outbreak of monkeypox in the Western countries, including especially in the United Kingdom, Germany, Spain, the United States, Canada, and other several countries. And the outbreak of the 2022 was something different from the previous outbreaks that had been observed in Africa. One is mainly the transmission was very high within a short period of time, especially starting from the beginning of May and until the end of July, there was high transmission rate, even though at the end of September it started reducing. And again, of course, the 2022 outbreak has some clinical and epidemiological characteristics which are different from the previous cases of monkeypox that was observed in African countries. One way is that in the current outbreak of monkeypox, it has been hypothesized that sexual contacts, especially sexual contacts among the male having sex with male, was the main transmission route. And it has been observed that this transmission dynamics of monkeypox has highly affected the MSM community. And another observation that has been seen was that even though the recorded cases of monkeypox for the 2022 outbreak was at the beginning of May or end of April, recent laboratorical and survey studies have indicated that the monkeypox has been spreading earlier than April in some countries. Okay, so as has been recorded in the public respiratory data websites, including in our World in Data, it has been observed that the case of monkeypox was has a high peak size around the end of July and of course middle of August, and as it has started reducing at the end of September, and mainly from January 2021, the cases of monkeypox was very low. And as the left-hand side of this figure shows at the 7-day rolling average cases of monkeypox that has been confirmed, and the right-hand side figure shows at the cumulative confirmed cases of monkeypox for different countries. Including, as you can see, that United States has highest number of confirmed monkeypox cases. But we couldn't include the countries from Africa here because there was no recorded data for monkeypox for the case of the 2022 outbreak. But what is alarming is that there was a news coming out from the WHO recently, which says that as we have observed in the previous case, it seems that at the end of 2022, the cases of monkeypox has started reducing, and at the beginning of 2023, the cases of monkeypox recorded was very low. But a recent study had indicated that in an African country called Democratic Republic of Congo, between January and November 2023, there was around more than 12,000 cases of monkeypox, and surprisingly, there was high number of monkeypox-caused deaths that has showed a fatality rate of 4.6%. This is telling us that public health preparedness is crucial in order to control such types of emerging and re-emerging infectious diseases, especially zoonotic diseases such as monkeypox. Okay, so the main research question that we want to study in this project was how can we quantify the basic reproduction number for the monkeypox dynamics? And second research question was how can we quantify the underestimated cases or fractions of cases of monkeypox for different countries? And the question will be, what is underestimation in this case? So we know that how to get data. There are different ways of recording data, and one of them is case reporting and surveillance. In the case of case reporting and surveillance system, this can be subject to different uncertainties, and the data that we see or we obtain from different data repositories may not tell us the real number of cases or the real incidence of the infectious disease, including monkeypox. And this uncertainty may lead to the underestimation of the fraction of incidences or the fraction of cases that are reported into the public repositories of data. And this underestimation may be due to three main categories. The first one is, we call that one underestimation, which is in this case, when all individuals does not seek healthcare. What happens is there are individuals who are sick with a certain infection, then they will not go to the health and the health institutions or to hospitals, or in general, they will not go to the healthcare. So those cases will not be recorded into the data. The other case is underdiagnosis. In this case, what happens is that when the infectious disease cases seek healthcare, but they are not properly diagnosed. And this is due to probably it may be the testing capacity or the testing kit, or it may be due to the less experience and less ability of the the individuals who are in the hospital who are going to test for this specific infectious disease. The third type of category that leads to underestimation is underreporting, or we call this one is under-notification. This is one of the main cases for developing countries. For example, in this case is when you fail to adequately report and notify definitely diagnosis cases to the respiratory system or to the WHO, CDC, and other organizations. And in that case, in general, what we have is that the infectious disease cases data that we observe, or these data that we observe, are not the real number of cases and the real number of cases of a certain infectious disease. And it is very important to use some mathematical, machine learning, or statistical approaches in order to estimate the underestimated cases of an infectious disease. So this is what we have. And as an input for this one, we consider monkeypox for different countries, and I'm going to show you in the second part of the talk how we have applied mathematical modeling and machine learning to estimate those underestimated cases of monkeypox. Okay, moving on, I want to easily mention that one of the consequences of underestimation is that it had two disadvantages in general. The first one is it may prevent evidence-based disease prevention and control, especially applied by health units and public health agencies. And secondly is for mathematicians, statisticians, or modelers, the underestimation may give them inaccurate numerical estimates of the key parameters of the epidemiological dynamics of the disease, such as, for example, inaccurate estimation of the transmission rate, the recovery rate, the hospitalization rate, and other parameters which are important for the epidemiological study of the disease. Since this is the case, it is very important to consider underestimated fractions of cases into consideration when we employ control strategies to control the transmission dynamics or hospitalization rates of a given infectious disease. And there are different reasons for that leads to underestimation. One of them is stigmatization or fear to go to the hospital and show your cases. For example, people don't want to go to hospital and indicate that they are HIV carriers. The same thing, one of the problems of monkeypox is that the symptoms, it's symptoms. There's a rash, there are symptoms on your skin, and then when you go to the hospital, people may get stigmatization because other individuals will easily observe and say that, oh, this individual is sick with monkeypox, then they will start trying to abandon them. And this is one factor, but still there are several other factors, including, for example, belief, the religious cases, and other factors that can be involved into the underestimation of cases. Then we are going to consider all of those factors or features into our machine learning based algorithm later on. All right, having said this one, then what we have done in the research context is the following thing. So what we did is, first of all, we tried to search what has been already done. And we have observed that, first of all, in terms of the mathematical modeling, there was no mathematical model that considers restructured and two-route transmission dynamics. When I say two-route in this case, is that we consider sexual contact transmission and then non-sexual contact transmission. And secondly, we consider two groups where we classify the population into risk structure, high-risk group and low-risk group. In terms of the machine learning, what we observed is that a few trials has been done in order to estimate the underestimated cases of infectious diseases using some certain types of statistical machine learning. And we try to extend this result by incorporating more inputs into the model. And again, we apply that one into the case of monkeypox. All right, so the last question that we want to answer is, what are the key determinants or key factors that led to underestimation of fraction of monkeypox cases? And I will conclude this one at the end. Out of all the factors or features that we considered, it has been observed that stigmatization towards the SMN community and religious beliefs are the two main factors that led to the underestimation of fraction of monkeypox. I will show in detail these ones later on. All right, so to summarize the study, we divided into two parts, and there has been two research outputs, published outputs for each of those two parts. The first part was on the mathematical model formulation analysis of the model by considering two risk groups, to route transmission. And again, we use the data for Canada in order to estimate the parameters. And of course, mainly, we tried also to see how adaptive behavioral changes and risk compensation has affected the dynamics of the monkeypox. And the second part is that I told you that it is on the quantification of the underestimated cases and the reproduction number, where we will see this one by using Bayesian interference for the quantification of the reproduction number. And then we use the machine learning in order to determine the key determinants and factors that led to the underestimation of monkeypox cases. So mainly I will focus on second part, but I will quickly show you what we have done on second part, which is on the mathematical modeling and analysis by considering adaptive behavioral change. Okay, so of course, this is very important. What are the main factors that we consider on second part is as features of the machine learning algorithm are stigmatization, cultural beliefs, and I say that one of the other one is healthcare accessibility. Also, we also consider people's inclination to disclose their monkeypox status. Okay, so the method. The first part, as I mentioned, is that we formulate a mathematical model which considers two groups and two routes for transmission case. And the second part is we quantify the production number and underestimation of fraction of monkeypox cases for 16 different countries. And we used the hierarchical clustering on mixed principal component analysis in order to determine the determinants or factors that led to the underestimation of monkeypox cases. All right, so the mathematical model that we had here is that, as I said, we classified the population into two groups. We have the high risk group and low risk group. And by considering this one, this is the schematic flow diagram that indicates the transmission dynamics of the monkeypox, where we have high risk group and low risk group. I'm not going to go in detail with the first part of the work. I will just go through the main result that we have obtained from the first part, and I will use this mathematical model for the second part. So the most important part in this case is we have the infection rate or the transmission rate here. We have two transmission rates. We have which are due to sexual contact rates and non-sexual contact rates. And we define this one here. We have the first one is sexual transmission rate, where it's given in this form. And we have non-sexual transmission rate, which is given this form. The first one for the high risk group, and we have the second one for low risk group, but the sexual transmission is considered only for the high risk group, which are the MSM community. And in that case, we have the force of infection for the high risk group is given by this expression, and the low risk group is given by this expression, where we have the important parameters here are the transmission probability due to sexual contacts and non-sexual contacts. And again, we have the average number of contacts per day, where we consider sexual contacts and non-sexual contacts. Having this one, then we also introduce it to our mathematical model is adaptive behavioral change and risk compensation. And in order to consider the adaptive behavioral change, we have looked into sexual contacts in the high risk group as the cumulative cases decreases. So in this case, we define our sexual contact rate given by this one. And of course, eta is a number between 0 and 1, which models the reduction in sexual contacts, which is also given by this one, where the plus this one indicates that if we have, for example, theta of plus in square brackets, then it is a maximum of theta and 0. Again, we define now the adaptive behavioral change is considered in terms of the doubling rate of cumulative cases. And here TEC is the total cumulative cases of monkeypox, and CT will be the doubling rate of monkeypox, where we have defined the derivative of the total cases by this one, and then we define now the doubling rate of the cumulative cases by this expression. And we introduce two important parameters. Here we have the first one is the doubling rate to induce behavioral change, and the second parameter, which is C0, will be the doubling rate that leads to half of the maximum behavioral change. These two important parameters will play a lot in the dynamics of the mathematical model that I'm going to show you. And this one is a result that has been published in the Journal of Medical Virology. Okay, what we observed here is that as the behavioral change, the adaptive behavioral changes, then the sexual contact number also changes. And we observed that the daily sexual contact number reduces globally over time. And we have chosen the half saturation constant to be 80%. And again, we have also considered 50%, and we have seen how it affects the dynamics. And the observation that we have in this case is that the smaller the critical doubling rate is, and the earlier the individuals in the high-risk group will proactively reduce their daily sexual contact rates. When they reduce their daily sexual contact rate, then it reduces the basic reproduction number, and which leads also to reduce the transmission or dynamics of the infectious disease. Having this one, then again, we introduce the risk compensation behavioral change, because when what we observe in this case is that when you practice proactive behavioral changes, such as, for example, use of condom, then this may lead indirectly to more sexual encounters as the compensation. And in that case, what we observe is that when we decrease the transmission probability by use of condoms, then this may increase the sexual contact rate in the high-risk group. And by assuming or fixing the initial risk is given by this expression, then we also have obtained a relationship between the average sexual contact rates and the base value of the average sexual contact rate, which is given by this one. And we consider this one into the mathematical model, and we consider data of Canada, for example, to only show this numerical results that shows us here. Then in this case, we plotted the incidence number of monkeypox cases for Canada, and we also consider different doubling rate of the induced behavioral change, where we have here is 50%, 25%, and 12.5% of the half maximum behavioral change that we consider. And what we observe in this case is that, as you can see here, we have this one, the incidence number. So the daily incidence number for the high-risk group decreases when we use the adaptive behavioral change. And as we apply more adaptive control, it is more effective to control the transmission than comparing to robust controls such as the use of condoms. And again, additionally, it shows that what we observe in this case, it shows that adaptive behavioral changes are better or more effective to control than robust control strategies. And we observed that the adaptive behavioral changes among the high-risk group significantly shortens the time to epidemics peak. As you can see that, for example, the epidemic peak when there is no adaptive behavioral change, or when we use less adaptive behavioral change, it shows that the peak takes time and the peak size is high. But when we use now the doubling rate to be 12.5% of the maximum behavioral change, then you can see that the peak size lowers, and again, the peak size is achieved on shorter period of time, somehow before 60 days. This is something that we have observed. So what we have is that the adaptive behavioral change can shorten the time to epidemic size. Again, it lowers the epidemic peak size, and again, it facilitates to reduce the cases or incidence of the monkeypox. And again, we also try to simulate the incidence by considering adaptive behavioral change and without behavioral change. This is the same thing that we observed in this case, and the concluding result is that if we are going to consider robust controls, such as, for example, use of condom only, then we need at least 35% of sexual absenteeism or use of other condoms in order to control the outbreak. But if we combine with the combination of both, then only 25% of complaints of condom use and 10% of complaints of sexual absenteeism is enough. But what we observed is that the use of adaptive behavioral change is more effective, because only 10% of the use of adaptive behavioral change will reduce the transmission of the disease. Okay, we also had some results related with the risk compensation, which also showed another dynamics by considering sexual absenteeism and condom use. All right, so let's move on quickly to the second part, which is mainly on the quantification of the reproduction number, where we used Bayesian interference in order to quantify the reproduction number for different countries. Then again, we could proceed to estimate the underestimated fraction of monkeypox cases. And again, we used the hierarchical clustering on mixed principal component analysis machine learning based algorithm in order to determine the factors that leads to underestimation of monkeypox cases. All right, so this is something that I already mentioned. I don't want to repeat this one already. I showed you. So this is the reproduction numbers that we obtained. We have 3 reproduction numbers here. The first one is the reproduction number for the whole population. Then we have the reproduction number for the high-risk group. Then we have the reproduction number for the low-risk group. And we have computed them, as you can see in this expression, where those expressions are given in this one, which are written in terms of the sexual contact rates and non-sexual contact rates and the transmission rates and other parameters related to the recovery rate and then disease-induced rate, days rate, and again, of course, the quarantine rate. This is for the whole population, and then the reproduction numbers for the high-risk group is also given by this one, where RH is given by this expression, and we have RLH is given by this expression, and then this one is the reproduction number for the low-risk group. And we are going to quantify each of those reproduction numbers for about 16 countries. All right, so yeah. And how do we obtain the data is that, so we consider a 7-day rolling average confirmed cases of monkeypox, and for different countries. These are the countries that we consider for the 2022 outbreak of monkeypox. And we also aggregated the extracted data into high-risk and low-risk group by assuming that all individuals in the high-risk group are like in the MSM community. After aggregating the data, then we consider 95% of those reported data in each country lies in the high-risk group. Okay, so the next one is, what we did is now the model calibration in order to quantify the reproduction number and fraction of underestimated cases is that we applied Bayesian interference. And in this case, by applying Bayesian interference, we estimated the sexual contact rate for the high-risk group. We also estimated the quarantine rate and the case estimation fraction for both the high-risk and low-risk group. And of course, we then quantify the reproduction number for both of the whole population, the high-risk group, low-risk group, and then we also try to quantify the initial number of infectious individuals for the high-risk group and the low-risk group for each country. In this case, we applied adaptive Hamiltonian Monte Carlo method in Arstein, and this one part was done by our collaborator, which is Dr. Sarafa from USA. And what does the adaptive Monte Carlo method, where we use the no U-turn, does is that the no U-turn sampler is a method for adapting the Hamiltonian Monte Carlo method to the local properties of the target distribution through the Monte Carlo algorithm. Having this one, then the next thing that we did is that how do we define the likelihood functions for each country in order to estimate the parameters that I stated earlier. So we come up with this formulation where we have the high-risk cases. Oh, sorry. The high-risk cases is directly proportional to the gamma function of the high-risk incidence times we have, this is pH, which is a fraction of underestimated population on, the fraction of reported cases on the high-risk group times some parameter phi, which will help us to do some inverse scale parameter. And then we define, after defining this one, we proceed to then do the estimation for each of these ones. So what are the determinants of the underestimated cases? What are the factors that we consider for the underestimation of those cases? The first one is, as we observe, is that we have to consider the case definition policy. What do you mean by, for example, diagnosis? Or when we say that it is recorded under a daily case or weekly case or monthly case, when was it tested? So WHO and CDC have their own definition for notification policy and for their way of defining what you mean by the tested or diagnosis or all these things. And so we have to consider those things into the model. And again, of course, we consider the attitudes towards the MSM community. We also consider religious attitudes. And again, then we have used the hierarchical clustering on mixed principal component analysis in order to determine the determinants or the factors that lead to the underestimation of monkeypox cases. And we observed that, I'm going to come back to the conclusion later on, but some of you may be wondering that where and how do you get the data, for example, for the MSM community? What proportion of the population for each country lies in the MSM community? And there are some freely available public domains where you can get data for the MSM community, and attitudes, for example, attitudes for the SM community can be obtained from the Equaldex platform, which is publicly available repository for data related to the SMS community. And one of those data is attitudes towards SM community for each country. And then the importance of religion by country is also extracted from the global GALPA poll, which has been conducted in 2009. And if anyone is interested, I can share the links for this one. And we also considered another data from different websites. After having this one, then what we applied is hierarchical clustering on the principal component analysis. What that the hierarchical clustering does is that, of course, the hierarchical clustering is unsupervised machine learning. It is an supervised machine learning method of clustering, which creates hierarchy of classes, or we call them clusters. And frequently, those are used as a principal component analysis, or they can use other data mining techniques. And why do we use the principal component analysis in this case? It is because helpful, one, in visualization, and secondly, it can help to confirm a good clustering, as well as it can help us to determine the k-means clustering, which is k-means is also another unsupervised machine learning that has been used for clustering. Okay, so this is some of the results here. The first one is that we had to, now considering those data, we had to fit those data into the model, and we have done this one for both the high risk and low risk group for each country, as we have seen in this case. And by considering 50% and 90% credible intervals for each of those countries. The first one is, for example, for we have reported cases which are obtained from our world in data, and then we fit those cases into the mathematical model, as you can see here. This next one continues for the next countries, which the first one was for 8 countries. This one is again for the remaining eight countries. And the next important result that I want to discuss is estimation of the basic reproduction number. And of course, in this case, what we have done is that when we estimate the basic reproduction number for the whole population and high risk group and low risk group, we considered 90% credible interval in. So this one shows us an increasing order of the estimated reproduction number for each country. As you can see, for example, in Canada, the estimated reproduction number for the whole population was 1.37. And then as you can see, this one is 90% credible interval. And it continues to go all the way with highest reproduction number for Germany, which is about 3.67. And we have this one is a 90% credible interval, as you can see in this case. And in the right-hand side, it is for high-risk group and low-risk group. And as you can see, this one is, we have on this one, the reproduction number for Canada for high-risk group with 90% credible interval. And for the low-risk group, and you can see that for the high-risk group, it lies between, it's almost less than 1. And again, if you move on to Germany, then for the high-risk group, it can go even beyond 1 and approximately 2 point something, which I'm going to summarize these results in a tabular summary, as you can see in the next slide. So what we have is, for example, each countries are here, and then the reproduction number of high-risk group, low-risk group, and the whole population. And as we observed that Germany has high reproduction number for the high-risk group and the whole group, but Canada has lowest reproduction number for both the high-risk group and the whole population. Having this one, the next result that we try to estimate, or the fraction of cases which are detected for each countries. And then the next part is the total estimated number of cases for observed case. What we did in the right-hand side is that for each one observed case, how many of them are not observed? Or in other words, for each observed case which is reported, how many cases are not reported? So this is what you can see in this case. For example, for Canada, for each one observed case, there were approximately on average 1.08 number of individuals which were not included into the data, or which were not reported, which is part of the underestimated fraction of population. And if we move on, for example, for the other country, Colombia has highest number of unreported or underestimated cases with 3.5 for each one reported case. Okay, so what we observed in this case is that the estimated proportion of cases of monkeypox reported for high-risk group range from 25% and 93%, and the smallest fraction is obtained for Colombia. That means Colombia has the smallest fraction of reported cases, only 25%. The remaining percentage of the real cases of monkeypox was not reported into the data. Okay. So we also see that highest estimation fraction of a high-risk group was obtained for Canada. Canada has highest reporting cases. It's only lowest cases of monkeypox which are underestimated or which are not reported for Canada. And we have also had some other results that we also done similarly for the low-risk group and high-risk group. And combining the high-risk group and low-risk group case estimation fractions, we also obtained the total number of estimated cases for each observed case for each country, as you can see in the following example. And in this case, we concluded that Canada has the highest underestimated or underdetected cases, but Colombia has highest unobserved cases or undetected cases. And numerically, we have shown here, this one is that it tells us, for example, the total estimated cases for each observed case. For example, for Argentina, for each observed case, there was a total number of 1.4 fraction of cases which were not reported, and it goes all the way in this one. All right. So yeah, similar results. And again, these are estimations of the parameters such as, for example, sexual contact rate, initial value, and others. We also estimate for each country. I just want to move on. I don't want to take a lot of your time. I can see that time is almost going. And the next one was the results related to determine the determinants or factors that led to the underestimation of monkeypox cases. And we, as I mentioned earlier, we used this machine learning algorithm in order to do this one, and we have obtained that out of all the factors and features we considered, attitudes towards the MSM community and importance of religion were the most determinants that led to the underestimation of monkeypox cases. And under attitudes towards the MSM community, there are other sub factors such as, for example, equality index, legal index, and of course, opinion index. So how do you measure? Someone may ask that, how do we measure or quantify attitudes toward this MSM community would be another question. And there are many indexes. Some of those indexes that frequently used are the equality index, the legal index, again, the opinion index. Then we have found the p-values of each of these indexes to be, as you can see that for each of these ones are the p-value of these ones. And of course, the importance of religion has a p-value of 0.01. And by using the importance of region, we also cluster the countries into two groups. The first cluster contains countries, as you can see here, mostly are United States, Belgium, Spain, and of course we have Canada in this one. And the second cluster are Chile, Colombia, Peru, Italy, and Portugal. And this one, this is to show that in each of those clusters or each of those countries, how religion is important in order to showcase or report your cases for an infectious disease, particularly for monkeypox in this case. And in this case, what we have seen is that the two clusters do not differ in terms of adaptation of the monkeypox diagnosis testing criteria and clinical criteria or epidemiological criteria or compliance with the WHO guidance. But the clustering key is depending on the importance of religion. But we try to cluster also depending on the WHO terminologies that are used to diagnostic, such as diagnostic criteria or clinical criteria or other complaints with WHO. So the clustering was not working in this way. All the countries were in the same group. But due to the importance of religion, the countries were clustered or classified into two clusters. So this is the result, more or less. I will conclude in 2-3 minutes. So what we observed in this case is that the underestimation rates for high-risk group and low-risk group varies between 25% to 95% for high-risk group and between 65% to 85% for low-risk group. That tells us that the data for cases of uninfectious diseases or cases of uninfectious disease are not the real number of cases or the real number of cases that are happening in real life. And this leads to underestimation of the cases or diseases of an infectious disease. And it is important to use mathematical, statistical, and machine learning algorithms in order to try to estimate some of the unreported or undetected cases and diseases of an infectious disease, which indirectly will be important to apply public control strategies to try to control or eliminate the infectious diseases such as monkeypox. And again, in this case, it is also important to consider which countries has highest number of underestimated cases or diseases. And of course, the other thing is for each infectious disease, the factors or determinants that leads to underestimation of cases or diseases are different. For example, in the case of monkeypox, we observed that attitude to the MSM community and importance of religion were the two determinants that led to the high underestimation cases of monkeypox. But it does not mean that it is the same for other diseases. It depends on the type of disease we consider. Of course. So yeah, I will end here, and there were some limitations that have been the limitations of this work. Some of those ones are we considered only 16 countries, and we didn't consider countries with endemic cases of monkeypox, countries mainly in Africa due to the lack of data. And secondly, the parameters that are chosen for the assessment of the determinants of the monkeypox underestimation in the machine learning are not enough. We could have used more types of determinants or factors into the machine learning algorithms, such as socioeconomic factors or clinical public health category characteristics, but we were not able to get data for those factors for each country. And secondly, we in our mathematical modeling and machine learning algorithm, we didn't consider public health pharmaceutical measures or control strategies such as vaccination or treatment. And yeah, I also acknowledge the support that I obtained from the CIHR, which is the Canadian Institute for Health Research, and NSEC, which is the Natural Sciences Engineering Research Council of Canada. And of course, I would like to thank my collaborators, as I mentioned at the big introduction of the presentation. I also thank you for the invitation. Thank you for the organizers of this seminar series, and thank you for OMNI and again CDM, which is Center for Disease Modeling, for organizing this talk, for the invitation. And thank you very much. If you have questions.
Thank you, Assefa. Thank you. It was a really great informative talk. It's great to hear your words. Is there any comments or suggestions? Please raise your hand to state, or you can write it down in the comments. We read for others. Let's see.
Hi.
Yeah.
Hi, this is Key. Hi, thank you, Professor, for the great presentation. So may I have a question?
Yes, please.
Okay, so in the data fitting of the first part, maybe in the pages 20, 21 or 22. So when you fit data, when you fit the model to the data, are all the parameters in the model fixed, or some of the parameters estimated actually from the data fitting?
Yeah, that's great. Okay, so I didn't showcase the data fitting. Okay, so in the case of data fitting, we estimated only some of the parameters. We had to fix some of the parameters because the data that we have for monkeypox is only the number of cases, or the 7-day average number of cases. So it is not good to make all the parameters to be estimated, because it will lead to high parameterization problem or high uncertainty. So we fixed some of the parameters that we obtained from literature. For example, there was average non-sexual average number of contacts. This is known for, it has been studied for different countries, for example, for other diseases. So non-sexual contact, average number of non-sexual contact rates. And of course, there was some other parameter, for example, the parameter for, what is this one? It's the, incubation period. The incubation period for monkeypox is also known from the WHO and CDC. So we had to fix some of the parameters and estimate other parameters.
Okay, I see. Okay, I got that. Thank you. Thank you.
Thank you, Fideng, for your question. Let's see. Is there any other question?
Yes, I can see a hand.
Yeah, I think Mark has a question. Yes, Joseph,
Yeah.
I think you are, oh yeah, Professor, who has a question too. Yeah.
Thank you, Professor, for that presentation. I would like to understand. You understand me?
Wow, there is an echo. I cannot hear you very well. There is an echo. Are you opening to Zoom? I can hear your voice twice.
Okay, thank you for your presentation, Professor. Thank you.
All right.
I want to understand the relationship between your machine learning model and your mathematical model, and I want to understand the data that you use, because I saw that you want to make the estimation of the higher risk group and the lower risk group. I don't understand. I didn't see the data, and I didn't see the relation that you have between machine learning and mathematical modeling.
Okay, so I think okay, first of all, what you have to think is, while I was presenting, I mentioned that there are two parts of the work. The first part was only on mathematical model formulation, analysis, and then fitting of the model into the number of monkeypox cases. That was the first part. Then the second part is now applying the machine learning in order to estimate the determinants, or in order to identify the determinants or factors that lead to the underestimation. And while we were doing this one, we also used the Bayesian interference in order to estimate the basic reproduction number, in order to estimate the fraction of underestimation, and again, in order to estimate the initial values under this one. So in that case, what we did is the following. Look, the machine learning algorithm is used only one cluster the countries by importance of religion and attitudes towards monkeypox and other ones. Again, the machine learning is used to determine which are the important factors or determinants that lead to underestimation of monkeypox cases. But we use the Bayesian interference in order to estimate or quantify the reproduction number, or estimate the initial values, or estimate other parameters that I mentioned. Okay?
Okay.
That's
Okay.
it. Okay.
Thank you.
Yeah.
Thank you. Yes.
Thank you.
Professor
Thank you.
Gu, yeah.
Huh?
Yes, Professor Gu.
Yeah, Assefa, thank you for this great presentation. Because I see just one small question.
Yes.
You have the result on Canada cases.
Yeah.
And claim that Canada has the lowest unreported cases.
Yeah.
So with your modeling, what conclusion you can get? So what is the reason behind this? Canada is there, the lowest of unreported cases.
All right. That's okay. What do we conclude from for this? That's a great question, by the way. So, okay. So what we have observed is that what are the factors or the determinants that incorporate importance of religion? Secondly, the attitude toward the MSM community. And then we have also people's attitude towards testing and diagnosis. So we believe that in Canada is, well, a free country. People are relaxed and people cannot hide their MSM community. And they are freely going to the hospital, report their monkeypox cases, or to go for the testing. This is one thing that we observe. Secondly, we observe that religion in Canada is not that much very diversified among population, and in that sense, religion does not prevent people to go for testing and to showcase their cases. Of course, these are some of the factors that we conclude that in terms of Canada, due to the Canada, one of the most democratic country where you don't discriminate people due to their religion, or you don't discriminate people due to their MSM community, and those individuals who are in the MSM community are free to go for testing, and they are freely showing their cases. That is something that we came up to conclusion.
Interesting. In fact, I learned that, for Canada, especially before or after or during the proud months, the public health, they have the vaccine campaign before and after the proud months. Yeah. So that would contribute to as a major factor too. So here, like, you didn't, because each country have different level of vaccination strategy.
Yeah. Yes, that is for other infectious diseases. We can also consider vaccination strategy and vaccination coverage or treatment coverage. But in our study, we didn't consider vaccination of monkeypox, so we didn't want to talk about vaccination into the determinants of the low underestimated cases and high underestimated cases. But you're right, that's also very important determinant factor for other infectious diseases.
Yeah. Thank you. Thank you.
Thank you very much.
Thank you. There are two questions. IVOC. Yes, Ivy, you can access the recording of these files on the OMNI-RÉUNIS site, as Shivika kindly attached the link. And there is another question, Jean-Jacques Rousseau.
Yeah, I can read the
yeah.
question myself. So it says, "That's well done. Thank you for your great presentation. My question is, what can we learn from this research to advise public health policymakers to help reduce the numbers?" Okay. Yes, that's a very important question and difficult to answer because of the policy and the rules of each country. Secondly, the health facilities and testing capacity of each country. Thirdly, as you see, for example, the culture, beliefs, and religion of each country differs from country to country. So it has been observed that the cases or diseases of an infectious disease that are reported or recorded in those public health repertory data systems does not really tell us the real number of cases and diseases. That means when public health policymakers are implementing intervention strategies, they have to consider into account that intervention strategy has to be implemented by not only considering the value or the fraction of cases or fraction of diseases that are reported, but we have to put further that there may be more number of cases or more number of diseases, and the control strategy has to be implemented into to cover large proportion of the population. That may be some suggestions that I can tell. And secondly is that we have to create awareness to public health policymakers that as the researchers or mathematical modelers, we have to recommend that there may be large percentage of underestimated cases or underestimated diseases that comparing to the reported or recorded cases. And those policymakers has to take into consideration those underestimated cases. That is what we can recommend as modelers or mathematical modelers. If there is anything that you may add, any of you can add.
Thank you, Assefa. Thank you for explanation. Is there any comment or suggestion, any question? I think there is no more questions. I might ask the final question. I really enjoyed your talk. There is only one part I want to get sure about it, to check my understanding. You made the Monte Carlo estimation by fitting data and later run the machine learning process.
Yeah.
Is your machine learning process based on the percentage of high-risk group?
Is the last you mentioned the last sentence. I couldn't hear the last sentence.
I said that you had some parameters based on Equadex platform or something.
Yeah.
I'm not pretty sure. And have you inserted in your model based on the percentage of MSM high-risk groups in different countries?
Yeah.
Because we won't have the networks totally. So
Yeah.
that is somehow adapting network setting, right?
Correct. So yes, we consider into our machine learning model, we consider the fraction of SMS population for each country. And the Equaldex is a website where you can get data for different factors related to the MSM community. One of those factors is attitudes towards MSM community, which is measured by different indexes. Or you can get different parameters related to the MSM community from that website. So we downloaded data for each country.
Right.
And then we incorporate that one into our machine learning algorithm. I think if that is your question, did I answer your question?
Yeah, that is. Thank you.
Okay.
Thank you very much.
Excellent.
Thank you, everybody, for joining our 16th series. Thank you, Assefa, for your interesting talk. If there is not any more questions, I can't see any more questions and comments. Thank you all for joining. We wish to see you for the 17th series and for the next talk 2 weeks later. Thank you, everybody. Have a good one. Bye-bye.
Goodbye.
Yeah.
Thank you. Bye.
Thank you. Thank you. Bye.
Thank you. Bye-bye.
All right. I gotta go and teach, and I have to teach another course. So
Bye.
I have to eat something before I go to my next class to teach. So see you. Thank you very much. See you another time.
Bye-bye.
Thank you. Thank you.
Yes.
Thank you. Bye-bye, Doctor.
All right. All right.